Medical education online. And it's free.
Chest pain in the post-operative setting comes down to two things. You want to make sure this patient isn't going to die. So you want to make sure they're not having a myocardial infarction and that they're not having a pulmonary embolism. What you're going to do is get an ekg, 12 lead, and troponins for the myocardial infarction, and you can get an ultrasound, the veins of the lower extremity, a CT scan with contrast, and assess the ABG. What you're doing is trying to rule out myocardial infarction, which is why you did the preoperative assessment to avoid this, and because they're laying around in bed, they're immobilized, and they just had a major surgery, the chances of pulmonary embolism are significantly increased, especially if it was orthopedic. If you identify elevations in troponins or ST segment elevations on the EKG, you need to do percutaneous coronary intervention. Give them a stent or heparin. You should never give TPA because they just had surgery. If you give TPA, they will bleed and they will die. If they have a pulmonary embolism, they need a heparin to Coumadin bridge. And if they already were on Coumadin, which is unlikely since you just operated, they need an IVC filter. That is, a repeat offender on Coumadin gets a filter. Altered mental status has a very broad differential in the patient who comes in from the outside. That is, someone who presents in the emergency department has a huge differential. But in the post-operative setting, someone with altered mental status doesn't have that broad of a differential because we're in control of everything. We replace their fluids. We give them electrolytes. We make them NPO. We've just done surgery. Chances are, if someone has an altered mental status, it's something we did. And so the things you're most likely to see are patients with disruptions of their electrolytes or hypoxia. And this is why, of course, we monitor these things. We get an SpO2 post-op and we monitor the Chem7s, the basic metabolic profiles. And the things to most likely disrupt mental status are the sodium and the calcium. Keep a track of these and replace them as needed. In addition, someone who's suffering from hypoxia, has a low SpO2, simply give them oxygen, a sufficient amount to keep their SATs, if they have obstructive pulmonary disease like COPD, between 88 and 92, otherwise everyone else above 95%. This is also why we give incentive spirometry to prevent atelectasis, to maintain ventilation of the lungs. These are the things you're going to see on the wards the most. The things you're going to see on your test are diseases like acute respiratory distress syndrome, ARDS. What you need to know about ARDS for surgery is you treat it with PEEP. It's a non-cardiogenic pulmonary edema, which is discussed in the medicine pulmonology section. But you suspect someone who has ARDS when they have a very tumultuous course. They've had major surgery, they're a trauma patient, they're a near drowning, there's a huge systemic injury, say the need to transfuse 15 units of blood to keep them alive. The patient has a tumultuous course in the ICU and then develops whiteout on chest x-ray. This patient may also present with hypoxia and shortness of breath. If you see the person with acute respiratory distress syndrome, put them in the ICU, intubate them, and provide them with positive end expiratory pressure. The one you're going to get tested on a lot, and that you can actually save someone's life if you catch it, is going to be delirium tremens, the DTs. You're going to ask every patient whether or not they drink. And they're going to say, no, I don't drink that often. But then on post-op day number 2, 48 to 72 hours after admission for their surgery, they begin to get hypertensive and tachycardic. And you say, well, they just had surgery, so they're in pain, increased pain control. But then they start to develop a tremor. and get delirious. If they have hypertension, tachycardia, tremor, and starting to get delirious, that person is withdrawing from alcohol 48 to 72 hours after they stop drinking, and they're about to seize. You prevent the seizures with benzodiazepines. Suspect delirium tremens in anybody who's hypertensive and tachycardic 48 to 72 hours after their surgery. So altered mental status has a very narrow differential. Of course, there are other things you need to consider, like medications or acidosis. But for the most part, what you're going to see on the wards is electrolyte and hypoxia, and the thing you need to watch out for is delirium tremens. The normal urinary output is greater than 0.5 cc's per kg per minute. In the postoperative setting, if someone presents with a decreased urinary output, that is not normal, and you need to investigate why that is. The first question to ask is there an urge to void? Because if there is an urge to void, urine is being made, but it's getting stuck in the bladder. And it is a problem of obstruction. The first thing you do when you found an obstruction is do an in and out cath. In general, if a surgery is going to take longer than 3 hours, a Foley is put in. But a Foley should be removed immediately after surgery because it is a nidus for infection. After that Foley is removed, a patient can go about 6 hours before you need to do an in and out cath. If there is the urge to void, you tell them they have to pee or they're getting recathed. But you do an in and out cath just to relieve the obstruction. Get out 250 cc's of urine or more, and then leave the cath out. Chances are it was just the shock of the body to surgery that led them to have the inability to pee. But you do have to answer the question, do you think they've got a long enough obstruction that won't go away? Do they need a Foley? In general, you want to avoid Foleys because they cause UTIs. But if they do not have the urge to void, they're probably in renal failure. That is, they're not making the urine they should. To assess this, simply ask, is there any output at all? Because in the post-operative setting, in a patient who you've known has normal renal function beforehand, for them to have no urinary output, that is, for them to go to making urine to needing dialysis, is extremely rare. And chances are, if there is no output whatsoever, you simply have a kinked Foley. You left that Foley in. Even though you shouldn't have, nothing's coming out. Simply unkink it. Or ask the nurse to flush it. This is probably a mechanical error of the device, not of the patient themselves. But if the patient does have some output, it's just low, now you're actually worried about kidney disease. And so what you're going to do is give a 500 cc normal saline challenge. The question you're asking, are they simply behind on fluids? Person's been NPO. We're controlling how much fluid they get. Are they just dry and they just needed a little bit more fluid? That is, if the urine output increases after the 500 cc bolus, they were simply volume down. And all we need to do now is give intravenous fluids to catch them back up. But if they have low urinary output because they're going into intrinsic renal disease, acute tubular necrosis, for example, giving them too much fluid might flood them because now they can't get the fluid off. We can put it on, which is why you only use 500 cc's. If there's no change with the urinary output after a challenge, now you're into intrinsic renal disease. We're going to talk about this in the medicine lectures. See renal. I want you to also recognize that this is very similar to the renal failure lecture in the medicine videos, except in the post-operative state, we go after obstructive uropathy first. post-renal obstruction is most likely to be present in the postoperative patient. And then only at the end do we decide between pre-renal and intrinsic renal disease. Next is abdominal distension. And what you need to do is decide whether or not it is a paralytic ileus, which is anticipated and expected, versus an obstruction, which is a surgical emergency, versus Ogilvy's, a frustrating distractor. The paralytic ileus is simply a metabolic derangement. We've just cut on their belly, now they're post-op, and so since we've disturbed the normal flow of their belly with a major surgery, it's expected that it takes some time to get going. So you'll see the patient on post-op day 1 who's passing no gas and passing no stool. On day 1, that's not that big of a deal, but what we want to do is make sure it's not one of these other diseases. So we get an X-ray, an upright, flat and erect KUB, an abdominal X-ray. And what we're looking for is a big, thick, distended small bowel that connects to a big, distended, large bowel. So if you look at the KUB and everything is distended, both the small bowel and the large bowel, you've got a paralytic ileus. This is okay. This is why we get the patients out of bed. We get them ambulating and we start diet. We give them a liquid diet and see if we can get things moving again. And that is in fact the treatment. Moving and eating will overcome the paralytic ileus. Of course, you also have to watch out for their potassium, since alterations in the potassium exacerbate this condition. But you'll see that everything is dilated. Everything dilated, paralytic ileus. This is different from obstruction, because in obstruction, the pathogenesis is either adhesions or hernias, and you'll see more about this in the small bowel obstruction lecture, that cause an obstruction to flow completely. The bowel is working, it just can't get anything through the obstruction. So the patient is going to present on your test as that patient with ileus that continues to day 5. You're worried about obstruction, so you're going to assess for the KUB. But now what you're going to see is an area of blockage. And distal to that blockage, the bowel is going to be thinned out and compressed, because all of the gas and stool that was present has already made its way out. And proximal to the lesion, you're going to see distension. This is a small bowel obstruction. If there's an obstruction in the large bowel, you're still going to see the same thing. Distal to the lesion, compressed, empty of air and stool. And previous to it, you're going to see the thick, distended, big colon. But because there's an ileocecal valve, air can't get back into the small bowel. So you'll see normal small bowel, big distended colon, and distal to the obstruction, compressed air. This is a large bowel obstruction. This is a small bowel obstruction. This is a surgical emergency. The patient needs to be taken to surgery now, especially if they begin to develop peritoneal signs. And finally, the distractor is Ogilvy syndrome. This is an ileus of the large bowel, and you're only going to see it in your post-op elderly patients. You're going to diagnose it with a KUB. And it's a paralytic ileus of the large bowel. So you're going to see a normal small bowel, a big distended colon, but that takes up the entire colon. There's no obstruction. There's no distal site that's empty of air and stool. The whole colon is distended. To treat this, you need to decompress them with a rectal tube. That is, get the air out. And because they're elderly, this may be caused by cancer, so they need a colonoscopy. To review, a paralytic ileus is a metabolic derangement that is anticipated on day 1. The patient will not be passing gas or stool, and you'll do a KUB in order to diagnose it, especially to rule out small bowel obstruction. Both the small bowel and the large bowel will be dilated. This is anticipated and is normal following gastrointestinal surgery. Getting them out of bed, getting them on a liquid diet, and monitoring their K is sufficient to treat them. An obstruction is the thing you worry about. It is a surgical emergency. It is the patient you thought who just had an ileus, but it continues despite your therapy. A KUB is obtained, and what you'll see either is a small bowel obstruction with dilated loops of small bowel with decompressed, absent air and stool distal to the lesion, or a large bowel obstruction where you'll see only partial colon dilated. The treatment is surgery. And the thing that's going to distract you is Ogilvie syndrome. It is an ileus of the colon occurring in elderly post-op patients. What you'll see is a distended colon. The small bowel is normal and there's no site of obstruction. Decompress them with a rectal tube and get a colonoscopy. The normal small bowel has some air in it, no loops, no dilations, connects to the ileocecal valve, and then the colon looks differently, slightly more dilated, and you can sometimes see the haustrations. There should be no dilations and no thinned out areas absent of stool or gas. After abdominal surgery, you're going to check the wound every day. And what you're looking for is to ensure you do not have the wound coming apart. And that can mean one of two things. There can be wound dehiscence, or there can be evisceration. In dehiscence, you have failure of the fascia only. This is going to lead to a hernia. And what you'll see is serosanguinous drainage. Pink on the dressing in the morning. Salmon colored. And really, this is just a clinical diagnosis. To treat it, you have to make sure that it doesn't become evisceration. The skin is intact, but the fascia underneath has failed. So you're going to bind them to keep the wound together. You're going to limit straining, especially increasing intra-abdominal pressure, and then electively take them to the operating room to correct the hernia. This is very different from evisceration. This is a failure of not only the fascia, but the skin as well. Basically, the wound just pops open. It's a failure of the whole wound. And what you're going to see is loops of bowel exposed to the outside. You're actually going to be able to see them outside of the patient. And the way it's going to work is either the medical student or PT comes by to work with the patient, or the patient tries to get up to use the bathroom. And as they strain, they increase abdominal pressure, they push the wound out, the wound comes apart, and the bowel pops out. This also is a clinical diagnosis. But this is a surgical emergency. You have to protect that bowel from drying out. So what you want to use is warm saline dressings. you want strict bed rest. Put that person back down on the bed. Do not let them get up or move. And then you go to the OR now. This is a surgical emergency. Never push the bowel back in. It has taken all of the bacteria that loop of bowel is exposed to by being outside of the sterile cavity and pushed it back in. That's terrible. Just cover it with a warm saline dressing and then go to the operating room as soon as you can. Finally, a product of abdominal surgery can be fistulas. Fistulas are an epithelialized tract between two structures. In the case of abdominal surgery, this is going to be a fistula from some part of the bowel to any other organ. And what you have to look for when you find a fistula, when you find this connection, is think of fetid. This is how fistulas form. Foreign body, epithelialization, tumor, irradiation, inflammation, and irritable bowel disease. This is generally why surgeons do not want to cut on inflamed tissue. Not only is it hard to identify structures, you also have a chance of creating a fistula and a distal obstruction. If a fistula forms, what you need to do is cut the fistula out. With a lift procedure. But unfortunately, sometimes what happens is that you can't get rid of the underlying problem, like a foreign body or a tumor. You may actually have to divert the bowel so that the fistula can close and heal.
We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.